So even that inflammation of the septal wall, so that will be appeared as Kerle B line. We can see in this image. Then there is an increased heart size. So this condition we are calling it as pulmonary edema with cardiomegaly. So that is what? Homogeneous bilateral perihilar opacity, that is called a bat wing pattern. Okay. So in the next X-ray, is it looking similar? Previous X-ray? Yes, somewhat. But here you can see here there is non-homogeneous. There is a non-homogeneous. It is not equal. Non-homogeneous bat wing pattern. We are not going to see any enlarged vessels over there. And there we are going to see in between this, we are going to see the patchy shadowing of air bronchograms. There is no cephalization, no Kerle lines. And anything cardiomegaly, can you comment? Is it there? No. Very good. So that is pulmonary edema without cardiomegaly. So usually we will find like these cases in the gastric aspiration. So whenever a patient want to vomit, so we have to allow them to vomit. Otherwise, if you hold the hand like this, so what will happen? One more episode will come, the patient may swell, or it may go into the back into the respiratory tract. So in those conditions, we are going to see like this pulmonary edema without cardiomegaly. So everyone know about it. Anatomy, that is a bronchopulmonary segment. How many bronchopulmonary segments are there? 10 in each lung. Right? So you can see here this is a trachea to principal bronchus, secondary that is lobar. After the lobar is a segmental. So in each segment you can see here upper, middle and lower. In the upper this is very important. This one yellow color, that is apical segment of upper lobe. And next thing is this one, you can see it is in line with this one. So this is what? Posterior segment of the lower lobe. Right. So this is what bronchopulmonary segment. They will aerate the particular area in the lung wall. So this is what we are going to see in the lung. We are going to see these are the alveoli or the air sac. Whenever these air sacs get infected, there is inflammation. Then after the inflammation, there is a collection of the fluid is there. That is what we call it as pneumonia. So in the pneumonia, we can see here like this X-ray. So in this X-ray, we are going to see there is a homogeneous air space or that is called a consolidation or opacity. Then here we are going to see some air bronchogram. What is air bronchogram means? You are going to see this is a bunch of the alveoli. All the alveoli are not filled with the fluid. So some are not filled. So those alveoli appears like a air bronchogram. Because air is present, so it looks like a white color. Black. White color. Black. Black color. So this is the pneumonia. And here at the hilum of the lung, some lymph nodes are enlarged in these cases. What is this case? Just now we have seen. This is pneumonia only. So here you can see the opacities for whole lobe. So this is called as a lobar pneumonia. Whole lobe is involved. But you can see in the other X-ray only one segment is involved. So that is called as segmental pneumonia. So only one segment is segmental pneumonia. Whole lobe, that is the lobar pneumonia. Then, so as we know that lungs are covered by the two membrane, that is the pleura. Pleura has the two layers, that is parietal pleura, visceral pleura. In between that we are going to see the fluid, that is the pleural fluid. So normally it is 5 to 10 ml is there. In some conditions that fluid is increased. So when the fluid is increased, that condition we are calling it as pleural effusion. What is that? Pleural effusion. When we are going to see in the X-ray, I said that we have to check the angle over here. So here you are not going to see that angle. So that is what we call it as blunting of postodiaphragmatic angle. blunting of. So here you can see, compare with the both the lung, here you can see the prominent, or we can see clearly the costodiaphragmatic angle. But here it is a blunting. So that thing we can say it as pleural effusion. Even in ultrasonography also we can find this one. You can see here probe has been kept over here. We can find the diaphragm and the liver. In between you are not going to see over here any of the fluid, but you can see here the fluid is here. So that is what the pleural effusion. Next thing, so this is what you are going to see here, that is a normal lung. In some of the what you call bacterial infection, sometimes there is a damage to the parenchyma of the lung. So there is a formation of the cavity because of the infection. So when the cavity appears, we can see it in the X-ray like this. You can find a cavity over here. So this is called as lobar or segmental. There is a space, black color, air space. But that air space has a prominent border. Okay, so lobar or segmental air space consolidation with prominent margin. So like this, you can see it is present in which part? Upper part or the lower part of the lung? Correct. So that is what pulmonary tuberculosis. In these cases, we are going to find like this. Even we can find the same case over here. In the X-ray, we can find like this. To confirm it, we may advise the CT scan. In the CT scan also you can find this is the air space with the prominent margin for the confirmation. Then the thing will come, what about these white part? So these all are the lymph nodes. Enlarged lymph nodes are there. In the lymph node we will classify if there is a less than 2 millimeter, that is called miliary lymph nodes. If 2 to 7, that is called as micro pulmonary nodes. And more than 7 and less than 30 mm, those are called as macro. If it is more than 30, we may go for it is like a mass or anything, we have to go for a differential diagnosis. Okay, so this is what the appearance is called as a powder puff appearance. Powder puff, which we use for the kids. Even we also use it, but only for the kids. Right, so in the next X-ray or next thing, we can see here there is the alveoli. In between that, we are going to see the connective tissue. That's a normal. But here you can see there is a thickening of the connective tissue. That's what we call it as. Whenever there is an infection, I say bacterial infection that is going to damage the parenchyma of the lung. Later there is a repair is there, but that repair is not like a previous. So that time there is a formation of the what we call the thickening is there. That is what we call it as fibrosis. In the lung fibrosis, you can see over here. This is what exactly is a scar. This is a scar over here. And with that, even you can see here, this is a trachea. The trachea is not present at the median plane. It is shifting towards the fibrous lung. So that we have to observe over here. So next, this X-ray, you can see here. Can you be able to find any air space here? Any air space? No. So this is what well-defined round opacity. This is well-defined round opacity is there. This is usually we find in the lung mass. I said when we can go for lung mass means, so that is should be more than 30 mm. 30 mm in the X-ray. So we can compare this with this one. So it is a round, well-defined round is a lung mass. Here there is a lobar consolidation. You can find like this in the pneumonia. Don't get confused between pneumonia and the lung mass. In the lung mass we get well-defined. Okay. So in the next X-ray you can see over here many dot white. So that is a multiple rounded opacity. Multiple rounded opacity. These are the enlarged lymph nodes are there. I said chest X-ray is advised in the follow-up of cancer patients. So whenever there is a abdominal, any other cancer, when they advise, sometimes we get like this. So that is what we call it as lung metastasis. So that is what appearance is called as cannonball appearance. Okay. So this one you are going to see the air space with a prominent margin, that is the lung tuberculosis, pulmonary tuberculosis, and this is what you are going to see without air space. You are going to see these are the cannonball appearance. So that is the lung metastasis. So this one special X-ray. Yes, yes, safety pin. It is in the airway. So that also we can find in the X-ray. So always we have to keep these things away from the kids, because nowadays kids are very smart. They want to taste everything. Next you can find this one. One more thing special. Mummy is or Papa is counting the coins. Kids have stolen it, kept in mouth and swallowed. Yes, you can see over here the coin shadow over here, but to confirm it we have to go for the lateral X-ray, because sometimes if that kid has over the locket over there, when you take anterior posterior, the locket also don't take, after seeing this, the coin is there in the respiratory. No. So to confirm it, we have to go for the lateral view. So if what you call locket is there, we can find it on the surface. Okay. So next thing I say, here it is a right dome of diaphragm, this is a left dome of the diaphragm, but here you are going to see below the right dome of the diaphragm, that is the gaseous shadow. So I said below the left dome of the diaphragm, gaseous shadow, that is the normal. If you are finding the gaseous shadow below the right dome of the diaphragm, that is abnormal. So we can find this one in the perforation. In the perforation cases, we can find the gas below the right dome of the diaphragm. It is an emergency condition. So moving to the next, that is a barium swallow X-ray. You can see here this person who is holding the glass. In that glass, water with barium is there. Then after that, he will swallow, means he will hold in oral cavity. When he is swallowing, they are bombarding the X-ray. So that is what we call it as a barium swallow X-ray. So usually the barium swallow X-ray, when the person swallow it, immediately they will take the X-ray. So during that time, what we are going to check? So we are going to see the lumen of the esophagus, whether it is filling properly or not. So when it fills properly, the image looks like this. So there is no filling defect over here. It is completely filling the esophagus. So in this case, you can see over here, there is some growth is there. Wherever the growth is there, you can see lumen is very narrow. Where the narrow is there, you can see there is a filling defect is there, narrowing. So in this, you can diagnose it as the esophageal growth. Nowadays, no one is doing this. Everyone usually will go for the gastroscope. So in this X-ray, you can see over here, it is normal filling. Here it is again narrowing, again filling. So it looks like a rat tail. Rat tail? Yes. So next is